mentioned, I'm a medical ophthalmologist, so I deal with the eye in relation to the rest of the body. Quite a rare speciality. There's only 15 consultants in the whole United Kingdom, and we all know Behçet's disease can affect the eye in many different ways. So I'll do a almost whistle-stop tour of Behçet's and the eye. There's a lot of jargon in ophthalmology in general, in uveitis, lots of Latin, lots of Greek. Some of it's still Greek to me. Hopefully it won't be for all of you. Throughout this talk, I've peppered it with drawings from a Romanian artist, Adrian Serghe, who has Behçet's uveitis, and his art just is quite evocative, just kind of portrays how it affects him emotionally. So as mentioned, I'm a medical ophthalmologist. This is a shoddy homunculus. The eye is related to the body in many different ways. Does anyone know who the chap on the left is here? One of my heroes. Really sadly left his original career as a doctor to become a writer. So he's a medical ophthalmologist called Sir Arthur Conan Doyle, who went into writing that, and he based his main character on his mentor on the right, who's Joseph Bell. The eye just gives you a window into the body in lots of different ways. So you get to see blood vessels, the immune system, the metabolic system, and there's nothing quite like it. And we're in this era of oculomics, so predicting, diagnosing systemic diseases often years before they can be spotted. Things using ocular biomarkers, things which are objective, measurable, and can evaluate the process of disease. And we're blessed in ophthalmology in that we've got lots of new technologies when it comes to imaging and diagnostics, and they're really combining with AI to make this a very fast-moving field. So history, I wanted to go back to see when was the first mention of anything relating to Behçet's and the eye, and it's one of the three fathers of Western medicine, Hippocrates, on the right next to Galen and Avicenna, and in his third book of endemic diseases, he describes what was effectively, seems like uveitis in the eye, although albeit lacking the anatomical precision to differentiate uveitis from other causes of redness or visual loss. But that's probably the first mention of uveitis. So I'll just really quickly go through manifestations, diagnostics, challenges, and future directions. Starting with manifestations. And we know that within Behçet's disease, ocular manifestations can be the most serious implications and can affect roughly 70 to 75% of patients with Behçet's disease. Up to 1/4 of these suffer from severe vision loss, and it's the sudden and the recurrent nature of uveitis, but particularly the complications of uveitis, which cause this. Men get uveitis more frequently and more severely than women. On the left, there's a survey of uveitis specialists showing what signs they consider most characteristic of the disease. So anterior uveitis, that's the front of the eye, we'll go through that, and retinal vasculitis are the most common, and retinal infiltrates. On the right is a survey of ophthalmologists in the United Kingdom, so any kind of ophthalmologist, even those in eye casualties, and asking them what's the most common manifestations that we see in eye emergencies from Behçet's, and it's usually vitritis, so that's inflammation in the middle of the eye, and anterior uveitis. But what is uveitis? So uveitis literally, itis means inflammation, uvea means grape, and that comes from the old term of the eye as a kind of grape, a big globe on a stalk. And it's inflammation of this entire uveal tract, which is the image on the right. So the iris, the ciliary body, and the retina. And you can divide it by different anatomical locations. So anterior, the front of the eye, where most of the inflammation can be, is where we generally focus on that anatomical distinction. So intermediate, the middle of the eye, and posterior, the back of the eye. Uveitis and Behçet's, mostly but not always of sudden onset, so people can wake up with dramatic loss of vision. It can be of limited duration usually, but it recurs. Both eyes are usually affected, but it's normally one eye at a time. Rarely just an anterior uveitis, often a panuveitis, all the layers of the eye, and occlusive retinal vasculitis, which means inflammation of the blood vessels at the back of the eye. And it's the blockages in that occlusive retinal vasculitis which is what causes damage to the retina and the optic nerve during the span of the disease, and that's what leads visual disability in patients. But what I always say about all types of uveitis, and particularly Behçet's, is that every single patient's different. Everyone manifests uveitis in different ways. I have a uveitis clinic on Monday, and some of the patients there can teach me about their condition as much as I can ever speak to them about it. So it's a very it's a complex entity in terms of how it presents, and each patient's journey is different, really. So even in Turkey, where there's a lot of Behçet's uveitis, they looked at photos. These are the uveitis specialists, and found that the incidence varied between 56 to 81% of uveitis specialists agreeing on whether this is Behçet's uveitis or not. But the main things they kind of concurred on were hypopyon, retinal infiltrate and bleeds, retinal hemorrhages, and also branch retinal vein occlusion, so the blockage of the vein in the retina. So again, lots of jargon, but we'll just quickly skim through all of these. Anterior uveitis, so inflammation in the front of the eye. That's the kind of bread and butter of uveitis in general in the country and the world. Classic symptoms are red, light sensitive, headaches, and what I see in my clinic are cells in the anterior chamber. These are inflammation in the front of the eye. You also see a flare. So flare is a foggy appearance, and that's caused by the protein which is leaked from inflamed blood vessels in the eye. Pupils often irregular, and there's features which we see, such as this ring ciliary flush. And in Behçet's uveitis in particular, there's often, or there can be, this hypopyon. So that's pus. Pus in the anterior chamber, and it forms that little pool because of gravity, and it can happen in 1/4 of very severe cases of uveitis. It suggests we need prompt treatments, so steroids and immunosuppressive therapies to reduce inflammation and prevent visual loss. But it does improve very quickly when the uveitis is treated, so that's a good marker of improvement of very severe cases. And it's quite fragile anyway. You find that even if patients shake their head, it can disperse and it becomes less noticeable. Another cause of painful red eyes, which I see quite often, although there's not much in the literature about just scleritis and episcleritis in Behçet's, but you do tend to see it in practice. This is again a cause of red eye, and it's inflammation of various layers of the front parts of the eye, episcleral vessels and scleral vessels, which are deeper than that. The distinction can be quite difficult to make. Episcleritis and is a bit less painful than scleritis, where the pain is severe and it's deep-seated. They can both improve with just local treatments such as steroid drops, but often you do need immunosuppression for the severe scleritis cases. And this is posterior uveitis, so this may be more dangerous and vision-threatening because it actually causes, in many cases, fewer symptoms compared to the anterior uveitis, which causes people to have red, light-sensitive eyes. So painless reduction in vision, but floaters can be a symptom that you can get. And where the haze and vitritis can be severe, it can be quite difficult to see how severe, how to kind of discern how bad this might be. These white spots over here, they're retinal infiltrates, so they represent active inflammation. Usually they disappear within days once treated with no scarring. This is retinal vasculitis, two different features of patients who have retinal vasculitis here. The one on the left is retinal periphlebitis. This is just inflammatory cuffing of this blood vessel. This is actually a retinal vein occlusion, and that can lead to fluid in the back of the eye, which is often treated by laser or injections in the eye, anti-VEGF injections. Again, symptoms that you might experience are decrease in vision, again painless, sometimes floaters, sometimes bits of your visual field which are missing. And this is one of the severe sight-threatening manifestations. So this is occlusive necrotizing retinal vasculitis. This is a photo that we do, an optos scan, so quite a nice wide scan of the back of the eye. This is a fluorescein angiogram, so dye is injected in the body and we get photos and we just notice the leaking pattern of vessels. So this is the same patient but different eyes, and the whole, there's some inflammation there, and the whole bottom part has been obliterated. This is the other eye, and you can see there's loads of vessels elsewhere, but here there's almost nothing. That represents that ischemia or damage to the blood vessels, and that's what causes the blackout there. So it's the complications of this which are the issue, which we'll go on to soon. A quarter of Behçet's patients with eye manifestations have an affected optic nerve. So this can be seen either as something called papillitis or progressive optic atrophy due to the vasculitis. That's damage to the optic nerve, which happens because of that inflammation in the back of the eye, and specifically the arterioles, which feed the optic nerve, the little blood vessels. Again, classic symptom of painless loss of vision, but with optic neuropathy, when the nerve is affected, there's a reduction in color vision and reduction in visual fields, which are very specific symptoms. Sometimes pain behind the eye as well, and pain on eye movement. But this is not the only cause of these kind of swollen nerves. Sometimes even clots in the brain or in the sinuses can cause raised pressure in the brain and can also cause swollen optic nerves. That's an example of the kind of patient I might share with our neurology colleagues. Hence why we have collaboration in our centres, because these, when they present, can span 2, 3, 4 different specialities. And then with Behçet's and many autoimmune diseases, we find dry eyes to be very, very prevalent. So a lot of my patients who might not have inflammation still suffer from dry eye symptoms. One thing which can drive this is this entity on the left called blepharitis. That is inflammation of the oil glands in the eyelids, sometimes associated with infection, particularly one organism called Staphylococcus. And anterior blepharitis is on the front of the eyelids, on the outer edge. Posterior blepharitis is on the inner edge. And that can drive dry eyes, which is on the right. That's again using that same fluorescein dye to look at the surface of the eye and just showing which bits are not being well lubricated. So when I see a very dry eye like we've got on the right, I would give a very intensive lubrication regime, a regime of drops, to make sure they're not experiencing all the symptoms you get with dry eyes, which can be sometimes paradoxical symptoms. So dry eyes cause pain, light sensitivity, headaches, but they can also cause a paradoxical watering. So people think, how can I have dry eyes when my eyes are watering? And that's almost a feedback loop which leads to overstimulation of the tear-producing glands, which aren't quite doing the job, and it just becomes more and more severe. So moving on to diagnosis, again, the art from Adrian Sergier there. These are some of the tests that we do in our clinic. So tests which look specifically at the function of the optic nerve, such as color vision, such as visual fields. Top left is the test which my technicians do the first, which is to check the visual acuity. And then on the bottom right is what I tend to do, which is use the slit lamp machine to look at the back of the eye in detail, from the front to the back in Behçet's, including the retina and the optic nerve, and also to measure pressure. And as I mentioned right at the beginning, we use lots of different scans, and there's new scans coming out or being explored. So on the left, I've got photos and Optos. Optos is a laser which creates a false color, false image, but gives you a lot of width, so you can look at the retina as a whole. In the middle, we've got that fluorescein angiogram, which in this case shows a retinal vasculitis. Sometimes you get this kind of fern-like appearance to indicate that there's leakage in the back of the eye because of vasculitis, inflammation of the blood vessels. And on the right is this ubiquitous OCT investigation that we do. So that's a cross-section scan that shows inflammation and the fluid in the back of the eye. Both of these patients have Behçet's uveitis, and on the bottom right there's a serous inflammatory retinal detachment, which usually improves with treatments. So now let's focus on the potential challenges. Uveitis, it sounds scary, but barn door uveitis is reversible. So it's up to ourselves as eye specialists, it's up to, in the community, our optometrists and our colleagues to spot uveitis early, to action the issues that we see early and prevent these complications from happening, because it's these complications which lead to loss of vision. So this is one called synechiae. This is synechiae, basically adhesions between different structures in the eye after inflammation, usually the adjacent parts of the eye having so many different layers and being such a complex organ. Sometimes people don't really notice symptoms with this, but sometimes it can make vision quite blurry. It's if they zip down the eye, if they really kind of impact the natural drainage of the fluid in the eye, like you've got on the image on the right, which becomes an issue because that leads to this, which is glaucoma. Glaucoma is damage to the optic nerve caused by high pressure in the eye. The uveitis in Behçet's itself doesn't cause raised pressure. Other uveitis entities can increase the pressure in the eye, but Behçet's by itself doesn't necessarily do that. But steroid drops are one of the treatments we give for anterior uveitis, can raise eye pressure. And if the inflammation does block the normal drainage mechanisms in the anterior chamber angle of the eye, so where the fluid which is in the eye is kind of drains out, that can cause angle closure glaucoma. And that can be really painful, can cause loss of vision, nausea and vomiting. And it's one of the things which can happen after vasculitis as well. So on the bottom left is iris neovascularization, new vessels forming in the retina, of course, but also as in the iris. And it's the one in the iris and the adjacent structures which can lead to something called neovascular glaucoma, which needs urgent treatment. So getting pressures checked is very important for anyone with uveitis. Cataract. Everyone will get cataracts if we live until the age of 100. It's just uveitis and the treatments we give for uveitis bring it forward. So cataract is clouding of the lens of the eye, and that causes blurring of vision, which is usually progressive, but you do get instances where the symptoms become obvious a bit unexpectedly. So sometimes their cataract just starts affecting the optic axis, and then they notice it. And we in our eye departments, we have all our colleagues who are ophthalmologists, everyone apart from me basically, can deal with cataracts, but just cataracts in the context of inflammation, such as you get in Behçet's disease, needs to be more carefully addressed and approached in terms of perioperative management, in terms of how you look at the immunosuppression, and sometimes, for example, I might just increase the steroids temporarily to cover a cataract operation. This is what we want to avoid. This is end-stage disease. So at this stage, there won't be any more flares of Behçet's. Here you've got, if you can see the optic nerves, they're pale. Then these vessels are coated in white. They've become what we call sclerotic. And multiple episodes of retinal vasculitis and vascular occlusions have basically damaged the structures in the back of the eye. So this is end-stage disease. At this stage, there's no further, unfortunately, there's no further treatment which can be done. And just in conjunction with the earlier talk from Suzanne Crozier, and obviously the sketches that Mr. Sergier, that I've put from his art on here, it's the emotional impact with Behçet's uveitis, which we need to be aware of. And sometimes within medicine, we're perhaps not so attuned to emotional and psychological effects. That's why there's been more recent studies looking at quality of life questionnaires, evaluating the importance of vision-related quality of life, especially in people with Behçet's uveitis. And they found that it serves as a significant predictor of depression and anxiety. And there is a bit of a feedback loop here, because we also know that flares of uveitis are also triggered by stress, by anxiety, by environmental changes. So, that's why in our national centres we have psychological and social support services, and why it's so important for many of our patients, and I've noticed with a lot of our Behçet's uveitis patients in particular. So future directions, I just want to take stock on where we're at currently. So this is on the left, just a kind of classic ladder of treatment with inflammation in the eye, going from masterful inactivity, the philosophical term, to drops, and even non-steroidal drops. I put steroid drops there, steroid tablets, then the immunosuppressants, which we've had for decades, and the more recent targeted biological therapies, which we've had since around the turn of the millennium. And on all levels of this ladder, there's scope to improve the treatment and side effect profile, and there's obviously always exploration of new potential treatments which are more efficacious and which have less side effects. So that's something which happens throughout autoimmune medicine. There's also improvement in surgical techniques. So on the right, the instance, which is still rare, but where there's just too much inflammation and debris in the eye, the only solution might be to take some of the jelly out of the eye, a vitrectomy, which reduces some of the vitreous humour in the eye. These kinds of surgical techniques are also being honed as well. Thankfully, not many people need that, but we have very highly skilled vitreoretinal surgeons who can do that. And we're in this era of innovations and biomarker discovery, so a better understanding of all the biomes of the body, including especially the microbiome, the gut microbiome, and how that affects inflammation in the eye and inflammation in the rest of the body, the genome, the proteome, so all these ohms, and understanding what leads to these persistent immune mechanisms, and hopefully finding new biomarkers and being able to quantify Behçet's uveitis a bit better using our scans will be what we're looking forward to soon. We've got new therapeutic targets which are always being explored, so these are some of them on the bottom right, everything from a particular gene to an immune disbalance to pathways and various chemical messengers which we call cytokines. I'm involved in some clinical trials for uveitis in general, which includes Behçet's uveitis for injections in the eye. So injections in the eye which aren't steroids, so don't have the side effects of steroids. They're still injections in the eye, but hopefully won't have some of the complications. These are for obviously severe uveitis cases. So hopefully there'll be exciting things coming out from that as well. And that's it really. I think, suppose my key takeaways are relating to the importance of awareness and early diagnosis of ocular involvement, and what we value so much in the NHS and within our 3 centres, which is that multidisciplinary approach to management. Thank you.